Hello listeners, welcome to Views on Health. Back with us on the program is Dr. Pravin Wijesinghe, consultant plastic surgeon, Teaching Hospital, Batticalow. The topic under discussion tonight is a cleft lip and palate, which is a birth defect and which again is something that we do see in children in Sri Lanka. Having said that, I would like to welcome you once again to our studio, Doctor, and ask you for a start, how common is this condition?
Thank you, Fatima, and welcome to the listenership. So the topic at hand is cleft lip and palate. It's a birth defect. In simple terms, it's basically where the lip has a bridging defect. Basically, the lip is incomplete in the midline, and also the same thing can happen to the palate. What I mean by palate is it's the hard part in the roof of your mouth, the one that you feel with your tongue. The palate has two parts. One's a soft part of the palate, which we call the soft palate, and then the hard palate. So you can get defects. You can get incompleteness of this shelf, if you say, from birth itself. The palate is the shelf that separates the nasal cavity, the nose, and the mouth. So it's a really important piece of anatomy that we have in our mouth. So why does it occur? Well, most of the time we do not find a cause, and we find that this has never happened in the history of that family, but we get one child with this condition. Sometimes it could be familial, in the sense the parents had it, now the children are having it, and if you trace it back, the grandparents may also have had it. Of course, the severity could vary. It doesn't have to be the same severity in all those generations, but it could have been there in a subtle form. Rarely it could be part of a syndrome. When I mean a syndrome, it's a collection of conditions that coexist at the same time. So for instance, a Trichocholin or Pierre-Robin or Van der Wood syndrome are some of the examples. They used to say that rubella was a cause for it. So that's why there's immunization program. Alcoholism in the maternal side could be a cause for it, and increasing maternal age can be cause for this condition. So how do they present? If there's a lip defect, it's obvious, it's out in the open. Parents are devastated by it because the newborn baby with a lip defect is so visual that anybody would say it. This defect could be a partial part of the height of the lip, or it could be the complete height of the lip, involving the complete height of the lip. Palate is not something that the parents initially see. It's something that the pediatrician or the neonatologist tells you about. They will come and say, because they're supposed to check all the parts as soon as a baby is born, and they're the first to sort of detect a palate defect. But if the baby is crying and then they're opening their mouth, you should be able to see the nose through the mouth, which you generally can't. These defects can be subtle. It could be just a part of the palate. It may not be the full length. It could be just a tiny bit of the lip, which parents may not sort of care about. And then we probably point it out down the line. Now, I detected a partial palate defect very recently in an 8-year-old child that came for something completely different. When I checked him for something, I detected that there was a palate defect. What's important is to detect early, because some of these surgeries that we do for these need to be done according to a certain time frame. These surgeries can be done at any time, but the functional outcome of this surgery is always better when it's done at the right time. So we always say that the pediatrician should be detecting them and should be referring them to us to sort them out down the line. It could be lip only, it could be lip and palate, it could be palate only, it could be unilateral, which is on one side of the nose, or it could be bilateral, and it could be inapparent, as I was telling you about. What's important to realize is when the embryo is forming in the mother's womb, the face forms in pieces. There's a top part that joins two side parts that forms the nose, the lip, the eyes, and so on and so forth. Any defect in this can result in this cleft lip and palate condition. But what you also would realize is something that affected that fusion will also affect the formation of the nose, teeth, and also the ears. So these can coexist with such deformity. So you need to make sure that they are assessed properly by other specialities also at the time we start treating them. So why does it matter? It matters. If it's a lip defect, it matters because it's aesthetic. It's so visual to have a defect in the lip. They can have feeding problems because when you start feeding a child where the palate is non-existent, it's the tongue that moves against the palate to push the milk through the system. So when you can't push against something because it's not there, they get feeding problems. Not only do they get feeding, but they also get nasal regurgitation. So they drink, the milk comes through the mouth. And of course, if there are feeding problems, this affects the growth of the child. So that's important. The child doesn't talk for a while, but then when the child starts talking, the speech is affected if you don't sort this out, because some of the sounds we make needs the lip, definitely needs the palate. So for instance, P, we use the lips to pronounce that. So if you don't have that, you can't pronounce the P properly. So there are lots of sounds that we make that needs the lip and the palate. And what generally happens is if the palate is defective, the voice becomes nasal. They start talking to their nose. So that's something that needs to be sorted very early in life. This is what I meant when I said that these surgeries need to be done early to prevent this. This surgery, even at a 40-year-old, you might be able to do the anatomical correction, but the functional correction needs early referral. Of course, the facial skeleton may also be affected. The malar prominences, which are these cheeks we have, may not be as well formed. They may have ear defects that need to be sorted out by an ENT surgeon, and they need to be seen early. So what do we do? What do we tell? We want to see the baby as soon as possible. The reason for that is we're not going to operate on that baby on day one, no, but that education is very important to the parents, because the parents are now going through such a turmoil having had this baby with so much hope. They don't know whether this child is going to be normal, whether this is going to be affecting the next child, how the growth is going to be, what's the future for this child. So we need to educate them. In these clinics, one of the best clinics that I've been to or I've worked at is at the Lady Ridgeway Hospital. At these clinics, you meet a whole host of people. It's a multidisciplinary approach. We just operate. But there's a lot of things that go on in the background. Nutritionists look after the nutrition. Orthodontists, dental surgeons do a lot to make the teeth look better and also to make sure that the facial skeleton grows well. ENT surgeons look after the ears. Some of these kids have ear problems. Speech therapists do a lot of work to get these kids talking normally. And I think they spend the most time with these kids, in fact. Genetic counseling, we have a geneticist that works with these kids in these clinics. Parents have a lot of questions. Is it a syndrome? Or if it is a syndrome, what is the chance of having the next kid with the same problem? And of course, we have the plastic surgeons that do operate on these kids. So the first... Yeah.
Doctor, just a question at this point in time. Now, the cleft lip, as you said, can be noticed straight away because it's very obvious. The palate, you said, has got to be checked because then there you have the pediatrician on the spot. And the pediatrician has to check the baby out. So, in other words, the pediatrician has to come at that point in time and say there is a problem with the upper palate. Because it's the palate that, that we're talking about on this program. And if the pediatrician says there is a problem, if he or she detects it, then you're not going to do anything immediately that very day, like you said, it'll take a while. But the focus then obviously is to make the parents aware of the condition and help them to come to terms with it. And having said that, at which point do you start your treatment?
Yeah. So the first visit basically is education. That's also very important to actually see similarly affected families, because you're alone when this happens. But it's always nice to sort of have the support of other parents who have gone through the mill sometimes, who already had the surgeries done. They also attend this clinic. We get about 15, 16, 17 patients, new patients in the same clinic. And when we talk to them all, they at least have a bit of comfort to know that it's not just them. And it's that, I think, changes the game. That just helps the family a lot. So at that first visit, we also start assessing. We assess the feeding. Is the child feeding well? We may need to do certain things. We may need to put a tube just to make sure that the child is feeding well. Sometimes when the child is feeding, the child doesn't breathe and they become blue. So we need to do certain things to make sure that that doesn't happen. The child might be already having infections through improper feeding. Infections need to be treated. Hearing needs to be assessed. Of course, the genetic counseling. And then if there are syndromes especially, these syndromes can be affecting the heart or the kidneys or whatever. And those need to be sorted out. Then we plan the treatment. So lip surgery is generally done when the child is about 5 kilos. And that generally means about 3 months. What they say is 10, 10, 10, so 10 pounds, 10 pounds, 10 weeks, like that. So generally the lip surgery is the first thing that gets done. Of course, the lip surgery might be very complicated, especially if it's bilateral, because there's a central bit that prevents us from doing a straightforward repair, and that needs orthodontics to sort of sort that bit out initially. The palate is operated at the age of about 9 months, when the child is about 8 to 10 kilos of weight. These kilos are important. Also the hemoglobin level is also important. So we do correct them over time. And when the child is about 8 to 10 years, the dental correction starts. And that takes a long time. They are fitted with certain devices to get the teeth straight, and if there is not enough bone, they do bone grafts. And when the bone grafts are done, if their teeth are not erupting through them, they need to put implants. So they do a lot within that time. Then around 18 years, we talk about the nose or the mid face if it needs to be done. What is important to know is there's a lot in between. Speech starts happening as soon as the child starts talking. The child needs to be sort of taught to pronounce things differently. And our speech therapists work on these kids day in, day out to make sure that they sound better. Even when the lip and the palate is made and they look normal, as soon as they talk, it becomes apparent if the speech isn't corrected. So they do a lot of work at that time. Sometimes when these surgeries are done, sometimes it's due to the incorrect surgery that's done, or sometimes it could be that something has become loose inside. Sometimes the children may need another surgery for the palate down the line, and so we do reassess them to see whether it works normally. It's not just about bridging a tissue. It's also about having a functional bridge of tissue, which basically the palate is basically not just a shelf, but it also has like a valve. It controls the amount of air that's passed through the nose, changing the voice from a hoarse voice to a nasal voice. So this function still needs to be there. It's not just about creating an anatomical gap. It's also about creating a functional anatomical unit. And that's where the skill of our operating surgeons come in.
Doctor, now once it's done, the surgery, do you have to have a repeat of anything? Or, I mean, you will assess the patient, but is it the surgery once and for all thing?
So the lip generally, once done, if it's done well, that's it. You do not need to sort of go back unless it's not done properly, obviously, because lip is an aesthetic organ. It has a cupid's bow in the middle with a white roll and a red roll and so on and so forth. I mean, it needs to look nice. of course, if it doesn't look nice, you can always go back and revise certain, but always the first surgery is the best surgery, and you do not want to try to revise it again, but you can. So, but the lip is generally, once done, it's done. Palate is what I was telling you about earlier. Sometimes once we do bridge the palate, when we assess the speech, especially when the child's head starts becoming big, the palate may not reach the back of the throat to sort of seal off. Now, for instance, when I say ah, most of the air comes through the mouth, but when I say no, some of the air comes through the nose too, and that's controlled by my palate. So if the palate doesn't control that adequately, we have a thing called a VPI, velopalatine insufficiency. Basically means there's an air leak. No, even after the repair has been done, we might have to revise that surgery if we want to give the child a normal or near normal voice.
So end of the day, okay, it's a good point that you would focus on getting it right first time around, but that's where the lip is concerned, and the palate you may have to revise.
Not always. Sometimes we might have to revise.
Now, in this situation, doctor, now obviously you're treating a baby. That's the best time, you said, after about, you said 10 weeks. And you wait for that period to get going.
We wait till a certain weight is built up. Because
10 pounds also, yes,
exactly.
Okay. In terms of kilos.
Yes.
So you have your guide.
We have a protocol,
yes, in which you have to follow. Now, obviously, in that situation, how does the child feed? Do you temporarily put in a tube to do some feeding? Because if the lip has been operated on, or the palate, it may not be possible for the child to use, or am I wrong? Can the child straight away have the milk without any issues?
Having a lip defect doesn't prevent the child from feeding, but having a palate defect can, because it's all about making a seal that makes the child swallow. So if you have a complete lip defect, you still get affected, because you can imagine they seal the nipple and the areolar complex of a mother with the lips, and then the tongue moves the milk in between the palate, which gets pushed down. It's pretty complex when you really think about it. So they can get affected. The thing is, we will teach them techniques to sort of prevent that from happening, and that's one of the reasons why the lip surgery is also done early. Especially with regards to palate, there are special devices made to make sure that the child doesn't reflux through the nose. So there are special nipples. It's not the bottle nipple that you always find. It's a special device. So this is what we do with regards to educating them. There's an amazing group of ladies that work on this, and they are the ones who teach the mother and the family to how to feed. And it's complex. It's not easy on the parents. It's not easy to feed, and they are the ones who sort of train the parents from day one. It's also really important where the genetic counseling is concerned, because some of these kids have recurrent problems. The lifespan might not be as long as for other kids. So it's always nice to get the geneticist to talk about this condition to the parents. And I should not actually forget about the fact that the nose can also get affected. So as I was mentioning earlier, at the age of 18, we need to sort the nose out. And why we do it at the age of 18 is, by 18, our facial skeleton more or less has grown up. We don't want to touch the nose at a younger age because it can further affect the growth. Plus, at 18, the child may say, look, I'm happy with my nose, just leave it be. If it's not a functional problem, I'm happy with it. Or if the child, the patient can make a conscious decision as to what particular surgery or when does he need the surgery, if at all. So
there you wait and do what you have to do.
So the
later.
Nose we wait. We do a bit to the nose. I mean, but that's subtle. at the early stages too. But I mean, the main nasal surgery gets done at a late age.
Have you come across a situation where the parents are more anxious and they say, "Doctor, we want you to do this for our child," when the child is younger, of course, and the child cannot make an informed decision? So in that situation, what would you do?
So the reason why we do it at a later stage is to also stop the effect of surgery. Every time we operate, that affects the tissues in different ways. We don't want the nose to stop growing. So we want the surgery to be done at a particular time of the child's facial growth. We don't want it done early. So we will definitely guide them. I mean, parents have lots of questions, and that's why I think they need to visit a center that has all the specialities that answer these questions. It's definitely multidisciplinary. It's not just the plastic surgeons doing it. It's also so many other people working behind the scene.
So end of the day, what is the psychological impact on the child?
I think that depends on how they're handled. It depends on how they are taught. It depends on whether they see other people, especially with lip surgery. If it's done properly, they become even the scar becomes nearly non-existent if you do it right. Of course, the severity matters. The severity of the condition, whether it's a palate also, whether it's bilateral lip or unilateral, all those matter. If the palate is unilateral, done by a proper surgeon at the correct time, they look normal. Because especially if it's just the pure palate, there's nothing outside. They just have stuff done inside, and there's nothing seen outside. So I think it's all about correcting. Our orthodontic teams do miracles. Our OMF surgeons do miracles with regards to changing the appearance of the patient. So I mean, everything is possible.
Just one final question. In Sri Lanka, are more girls affected or more boys affected?
I think girls are more affected. But I think that's global studies.
Why is that?
We don't know.
No answer to that at this point in time?
Yeah.
Mm-hmm. Okay, doctor, it's been very interesting again. And what would be your take-home message?
Take-home message is there are options available to the young parents that do have a child. These options are best given at a place that offers all the specialities. So come and talk to us. If you're in Colombo, to come to Lady Ridgeway, because I think that's where the best of the best give you the best service possible. It's always nice to talk to us early. There are lots of questions. Trust me, you're not alone. And if you know someone who has that, send the child and the parents to us early on so we can get on with the plan.
Thank you, doctor. On that note of advice, we end another interesting discussion, this time on cleft lip and palate. And thank you very much, Dr. Pravin Wijesinghe, consultant plastic surgeon, Teaching Hospital Batticaloa, for being with us once again on the program and for sharing your expert knowledge with our listeners on this very important topic concerning children.
Thank you, Fatima. Thanks.
Pleasure, and we hope we see you soon in the foreseeable future. Thank you to Harsha Nivana Guru for technical assistance. I'm Fatima Razi-Kada saying good night and looking forward to your company next Monday, same time on Views on Health.